Welcome to the second talk about looking at the chest. This time, we'll talk about looking at the heart. Obviously, echocardiography is a very complex field, but today we will talk about two key pieces of the emergency echo: identifying and interpreting pericardial fluid, and knowing what to do with cardiac views during cardiac arrest, which, as you will see, actually applies to any peri-arrest patient as well. There are a lot of other components of the critical care echo, which we will only briefly touch on today, but we'll plan on exploring in more depth once everyone is on board with the basics. Today, we'll talk about just one view of the heart, called the subxiphoid view. In this view, the transducer is placed just below the xiphoid process and aimed up into the chest, which will often involve a pretty flat angle relative to the torso. When you do this, you will see this image with the liver in the near field, followed by the structures of the right ventricle and right atrium, and then the left heart sitting in the deeper side of the far field. You can now observe the synchronous contraction and valve movements of the cardiac cycle. The first thing to look for is a stripe of black fluid in front of the heart, which represents fluid around the heart, seen here in red. Remember that just like with abdominal fluid, free fluid in the setting of trauma, especially penetrating trauma, should be presumed to be blood, but in the setting of a medical patient, this can be uremic, infectious, malignant, or inflammatory, which might change your management. Once you've identified the free fluid, take a close look at the way the right ventricular free wall closest to the near field is moving, and watch for collapse of the wall and the right ventricle during diastole, which would represent obstructive impending shock due to tamponade. In this clip, the RV wall looks normal without any collapse. Here's an example of early tamponade. Note the bowing of the ventricular wall just at the end of diastole. This is sometimes referred to as a trampoline sign because it looks like someone is bouncing on top of the RV. Here's a more obvious video. Here, the RV is almost fully collapsing at the end of diastole. One thing to be aware of, though, is that the presence or absence of tamponade does not depend very much on size, but rather on the rate at which the fluid is accumulating and the pericardial sac is able to stretch to accommodate that fluid. The effusion here is actually pretty modest, but there are pretty clear signs of tamponade. On the other hand, here is a much larger circumferential effusion in a dialysis patient with no signs of tamponade, likely because this is a more chronic uremic effusion. And that's a common pattern. Medical circumferential effusions accumulate slowly compared to traumatic hemopericardium, which is more likely to cause tamponade even with small effusions. Identifying tamponade is not just an academic curiosity. In this study, the authors looked at pre-hospital ultrasound in Germany during cardiac arrest and severe shock states, and found that 13% of patients with PEA actually had tamponade, and all of these patients survived to hospital discharge after successful relief of the effusion by pre-hospital paracentesis. So ultrasound can help you differentiate the patient who's dead from the patient who's only mostly dead.
His daddy can't talk.
Ooh, look who knows so much, huh? Well, it just so happens that your friend here is only mostly dead. There's a big difference between mostly dead and all dead. Please open his mouth. Now, mostly dead is slightly alive. Now, all dead, well, with all dead, there's usually only one thing that you can do.
What's that?
Go through his clothes and look for loose change.
So how else can ultrasound help you in cardiac arrest? There are three big ideas I want to get across for the remainder of this talk. First, I want to talk about the importance of defining cardiac activity. Second, I want to talk about the notion that the electrical rhythm that you see on the monitor is not always the same as the mechanical rhythm of the sick heart, and that sometimes that mechanical rhythm is more important in guiding management and predicting prognosis of a sick arrested patient. And finally, we will talk about the importance of situational awareness during a cardiac arrest, and not wasting time while doing ultrasound during a code. Let's start by defining cardiac activity. This has long been a focus of debate because it used to be defined the way Judge Stewart defined pornography. Oh, you'll know it when you see it. We now know that if you use such a loose definition, there's a lot of disagreement, which definitely is not good when you're in literally a life or death situation. So based on several recent studies, we'll now define cardiac activity as this: myocardial contraction, meaning the myocardium is contracting and those ventricles are getting smaller. That black is getting smaller. And this needs to be enough to produce forward flow, rather than just movement of blood in the chambers or isolated asynchronous valve flicker. Here's the obvious example of good cardiac activity that we looked at earlier. And here's another example. I swear this video is playing. This is clearly no cardiac activity. There is no movement of anything in this heart. Now here's an excellent example demonstrating the absence of forward flow. When you use IV fluids or meds and pushing them very fast in a coding patient, you'll often introduce little air bubbles. This can help visualize the absence of any transit through the heart, despite some occasional isolated flickering valve movements. This also represents an absence of forward flow, and so doesn't meet our definition of cardiac activity. Here's an example of a common fakeout. This is the same patient as in the first example, but it almost looked like something is now happening. What is it? This is what happens when somebody is squeezing the ambu bag and inflating the patient's lungs. This squeezes the heart from the outside and produces isolated valve flutter, but it is not myocardial activity. Cool. So we defined cardiac activity. What do we do with this information? Remember that one bit from Nightmare Before Christmas?
Interesting reaction. But what does it mean?
Spooky, right? What to do with this information came into a bit of very blurry focus last year with a massive publication of what is now known as the REASON trial. This was an observational, prospective, but protocol-driven study. The authors looked at the echoes of 793 patients in PEA or asystole in their emergency departments all over the country. And by protocol, the participants had to continue CPR for at least one cycle after performing the ultrasound. They found that positive activity definitely had a strong correlation with survival to hospital discharge, with an odds ratio of 5.7, which is excellent since we all kind of presume that a beating heart is much better to have than a non-beating heart. But, and here's the kicker, 3 patients with this ultrasound made it to hospital discharge neurologically intact. Who were these 3 patients? There was a 64-year-old man who was found by EMS and VFib, shocked into asystole, and had a 40-minute emergency department resus, walked out of the hospital neurologically intact. There's a 67-year-old man found in VFib, shocked, PEA, 6 minutes ED resuscitation, walked out of the hospital neurologically intact. And finally, here's a weirdo, 75-year-old woman found in her bed in asystole with an unknown downtime, resuscitated for 20 minutes in the field and then another 10 minutes in the ED, made out of the hospital neurologically intact. Here's what I said when I heard this. What? So, what? Let's listen up here for a second. First, this trial did show something we've all suspected and have relied on in our resuscitation. It definitely showed that cardiac standstill is very bad. It just asks us not to rely on this alone and use the rest of the clinical picture to guide management. And we'll talk in a moment about how to delay the decision to stop the code while you synthesize that same clinical data. We also learned from the REASON trial and some of its post-hoc analysis that when ultrasound is used to guide resuscitations, you can get markedly improved results. So how can you use ultrasound to help guide your management? The REASON trial and the pre-hospital German trial I showed you earlier helped answer this question by introducing the notion that the electrical rhythm that you see on the monitor doesn't necessarily tell you what the heart is actually doing mechanically. ACLS algorithms all rely on rhythm analysis to feed into a particular algorithm, and this is great if all you can get is an electrical rhythm. But it turns out that the mechanical rhythm of the heart is actually much more helpful in guiding management and predicting the outcomes. For example, here's the ACLS poster perfect asystole rhythm strip. However, when you put the probe on, this is what you see. This is actually not standstill, but rather a very fine ventricular fibrillation, which you can only see by looking closely at the myocardium and seeing that it looks like it's filled with a small wriggling worms. This patient needs a shock. Here's another example. See that wriggling bag of worms in the myocardium? Shock. Here's a somewhat more obvious one. Same deal, VFib, shock. It turns out that when treated like VFib, these patients have a survival approaching that of actual VFib patients, which is good, rather than those of asystolic or PEA patients, which is generally very, very bad. Another example of this kind of difference between the electrical and mechanical rhythms is the case of the heart with some but very poor activity, which can happen in both PEA and in asystole. In this case, there is some synchronized activity, but the patient doesn't have a palpable pulse. The best way to assess this kind of poor activity for now is to eyeball how well the myocardial contractions are able to make the chamber size smaller. There are a lot of fancy names for this phenomenon of myocardial contraction in pulseless patients, like PEA, pseudo-PEA, and my own personal favorite, old-fashioned electromechanical dissociation. But really, let's call a spade a spade. This is a patient in cardiogenic shock. So treat them the way you would any other patient in shock. Use pressors that make sense for the patient's physiology. And don't just blindly push industrial quantities of these pressors every 3 to 5 minutes. Set them up as a drip and titrate up until you can reverse or at least temporize the shock. I know that might not be a popular statement in pre-hospital medicine, but again, the reason in the pre-hospital German trial showed that patients who had this kind of pattern did much better with a drip than blindly following ACLS. So finally, how and when should we do this? Codes are inherently hectic, and we know that any pause in compressions precipitously drops the coronary perfusion pressure. In 2017, 2 high-profile trials were published in Resuscitation that really drove home the message of how much we could harm our patients by focusing too much on ultrasound during a code. They were small trials with only about 25 patients each, but they showed that rhythm check pauses with ultrasound were much longer than pauses without ultrasound. 21 versus 13 seconds in the first study, and 17 versus 11 seconds in the second study. So if you subscribe to the belief that high-quality chest compressions are the cornerstone of cardiac arrest management, and also subscribe to the belief that ultrasound helps us find ways to delineate between all dead and mostly dead patients and improve their outcomes, this seems to be very bad news. So how do we flip that frown upside down? One thing that's been proposed is to have a systematic way of doing your rhythm check and ultrasound. Hopefully, you all already prep for your rhythm check by pre-charging the defibrillator about 30 seconds before the rhythm check. Add to this prep by placing the probe in the subxiphoid spot during chest compressions before you even pause for the rhythm check, and start looking for your window. As soon as the pause happens, hit the Save Loop button, which will start recording a 6-second clip. At the end of the 6-second clip, you'll hear a beep, at which point,
move! Get out the way! Get out the way! Get out the way!
I cannot stress how important it is for you to move. Get out the way, let the compressor resume compressions, and now you can look at your clip and interpret it. Look for activity and decide, is the heart even doing anything? And then, if you do see activity, you can start looking at the differences between the mechanical and the electrical rhythm and start doing something about it at the next rhythm check. So today, we talked about identifying pericardial effusions in trauma and medical patients and the differences between the two, identifying tamponade by looking for RV collapse, and remembering that effusion size is not necessarily the same as tamponade. We also touched on the basic analysis of the heart during arrest, specifically being very careful when defining activity, separating out the electrical and mechanical dissociation between the two rhythms, and making sure that you're not killing the patient by wasting time on ultrasound. Thank you so much for sticking with this curriculum. There are some cardiac references at the very end of this video, but first, I'll leave you with the first few verses from a little ditty from SMAC 2015 in Chicago.
It's all to stand up, maybe, because we're celebrating ultrasound today.
Do this? Oh, wonderful. Love it. Come on, guys.
Imagine there's no X-ray.
It's easy if you try.
No CT scanner.
And no MRI.
Imagine all